Thanks to everyone for joining our session today. We do have the Rockstar back again this week for anyone who was with us last week, and we've updated his title to the appropriate one. So any questions for the Rockstar, please pop it in the comments here on Facebook, or pop it in the comments here in Click Meeting as well. Just be mindful as well before we start that the Q&As don't take the place of a consultation with your own clinician, and these sessions we're aiming to provide general medical information and not medical advice. Also, just remember, Facebook's a public place, so you can get more privacy if you come and join us in the room here. So welcome, Professor Jones. How are you?
Well, I'm recording a new album and ready to go out on the road.
Is there an autobiography coming soon?
Yeah, it's funny. No, and I'm upset because I did demand a bowl of M&Ms with the orange ones taken out from a thing. I am actually, seriously, I'm going to write, this is not a joke, I'm going to write my life in liver medicine when I retire, because it's been a crazy journey in so many ways. So it's going to be the story of my life in liver medicine. I'm going to call it 50 Shades of Yellow.
That's not a joke. That's not a joke. Going to ever allow you to retire, though, so I'm not sure when you're going to get time to do that.
50 Shades of Yellow.
Right, I'm just popping a wee message in the chat here on Facebook as well for any questions for us, and then we'll get started on the questions that have been sent in to us. So the first one on the list today is a question about stress. So we've got a patient who's having stress. Yeah. So we've got a patient who's having 24/7 stress due to work, and she's concerned that that's affecting her liver. If so, what happens for her now and potentially in the future, and how potentially could she help avoid this stress if her job doesn't allow it?
So I think that's as they always are, a really good question. And we all live in the real world, don't we? Where people have sort of a chronic health problem, that adds to the stresses and pressures of the real world, and workplace pressures are there. One thing that we often end up talking about, it's actually a term that I hadn't heard of until fairly recently, which is the sandwich carer, where people are caught in the middle between looking after their own children and also elderly parents who are quite dependent, with both of those not really understanding things. And I think it's a very useful term. I think it describes a lot of people's experience. And also in general, we've become a bit of an intolerant society, I think, and people don't understand and kind of sympathize as much as they could do. And I think also people don't understand, and this thing about not looking like people are ill can mean that it can be quite difficult. So it's a common issue. Just to talk about the PBC aspects of it, one of the things that we do know from lots of research is that PBC patients do suffer from more anxiety than other people in the population, similar age and gender, and a little bit more depression. And actually it's more anxiety than depression. And certainly that's something I recognise from the clinic. Does anxiety cause PBC? No, almost certainly not. Do people struggle with things that makes anxiety worse? Possibly, because you lack reserve. I think that's a term we use all the time. You've got no spare coping capacity to be able to deal with things, that you're going full out to be able to do ordinary things, and therefore having to deal with additional things, is problematic. So it is an issue, and it can sometimes really get on top of people. And we talk about this very openly in the clinic in I think, a very positive way. So sometimes talking about it, being a sounding board is very helpful for people. Sometimes that's not enough, and a short course of medicine is useful. and we tend to use sertraline. People think of it as an antidepressant. It's actually more effective as an anti-anxiety treatment. For a length of time, it can help people go from where they are to where they want to go and kind of get things into perspective and get a bit of coping capacity back. So that's something I've done very commonly, and people appreciate it, then stop it because they've managed to, slightly get on top of things. The one thing we wouldn't do with anxiety is do it the old-fashioned way with benzodiazepines and things like that. That's always doomed to problems with PBC because they accumulate because of the liver disease. So sometimes that's useful. In terms of talking therapy, it's very useful in certain situations. My experience is that by the time people come to talk to me about that, they've done that. They've done it with their family. They've done it with the foundation. They are very rational, and it's just trying to get started at putting things in place. And so that's why we often go for that. And the one thing we never do is something that I suspect will be sadly familiar to many people, which is this, the doctor says that bit's nothing to do with me, go and talk to one of the other doctors whose bit it is, and you get that from all the people you go and see. And we never do that, unless it really isn't anything that I've got any knowledge about, because it's sort of anything your problem, and having people tell you about your problem that it's not their problem doesn't help. I think in terms of talking therapy, it's one of the areas that the NHS is really struggling with at the moment. Ludicrous waiting times for it all, and I think that's why we sort of crack on and do it ourselves. So specifically about the question, very stressful at work. The two directions of that, so work making stress worse and stress making the PBC worse, if you like, are worth thinking about. So the whole area of stress and disease is a complicated one. There is a science called neuroimmunology. The immune system is affected by the brain. It's a well-recognized phenomenon. And so it is likely that stress hormones, adrenaline, cortisol, that people are familiar with, probably do make these conditions worse. It's a lot of people talk about a stressful event before they got the PBC. It's difficult to know, whether one led to the other, but a lot of people do talk about it. And I think, there is a danger that when people are having a really hard time, both the disease can be a little bit worse, I suspect, and also your ability to cope with it is a little bit worse. And so therefore the two go together. I think a good employer wouldn't put people under stress, okay? And I think that's very important because we do have a system, and this is where we'll talk about the concept of reasonable adjustment, where we do have a system where employers do have to take on board significant health issues and do the very best that they can to support people. Actually says PBC Rockstar on there, doesn't it? Isn't that wonderful? Yes. So employers should listen to your needs and adapt what you do in order to help you to do your job. And of course, really good employers who do that, everybody wins because you win. Because you are able to do a job that people frequently like, and the stress of not being able to do it goes away. But I think the employer wins because they're seen to be a good employer who cares about people, and that means people want to go and work there. I make that point to employers all the time, is that it's times like this you show whether you're any good or not, and whether you deserve to have people. And all employers will tell you that it's the retention of people and absenteeism through illness are the best signs of a healthy organization. So organizations that are not healthy, you lose people, they move to other jobs, and you get more in the way of sickness. Some sickness will be inevitable when you've got PBC, of course it will be, but we're talking about disproportionate. I have to say, as somebody who works in the public sector, and I know Mo did this before she came to the PBC Foundation, public sector is not very good at this, I have to be honest. There are some private employers who are really good, and we've written up our experiences of that and shown them to other people. This is what you can do if you really care. And actually, they take real pride in it. And there are certain things that are really helpful, like not working night shifts, being able to be a little bit flexible about what you do. And so I think if you have a legitimate reason, you've got a chronic disease where coping strategies are an important part of it. And if work is contributing to your perception of illness, then it is contributing to the illness. And I think that's a conversation to have with the employer. I have to say, over the years, less so than we used to, we would interact with the unions about this, and they're pretty good about this. So this is one of the things that they do, is support. They know the law inside out, and they support people around these things. And I have to say that's often been very effective. So going in as a support with it all, with our input and guidance. So I would say I wouldn't just take it. I would say, can we possibly, look at reducing the impact of all of this, because it's an important part of it all. And, that's the answer to this, not medicalization. But at the end of the day, if it's getting too much for you, then whilst you're, developing your fighting kind of side to sort this out, you might not have the kind of mental bandwidth to be able to do that. And that's where something like a short therapy intervention, might be helpful. But I think it is a factor in the totality of people's experience, for sure.
Yeah, and I just wanted to add to that we're here to help with that as well. If you're considering having a chat with your work about reasonable adjustments, or considering if your work might have an employee assistance scheme that you could speak to, or anything like that, please just give us a call on the helpline and we'll help talk you through that. We can help provide some literature for your employer if that helps as well, So please use our...
And remember, the term reasonable adjustment is not kind of an adjustment you might make that feels reasonable. It's a legal term. It's a legal obligation on employers.
Yeah, you will have rights for that. Yeah. And also just to mention as well, I know that on our Cheryl hosts on a Tuesday, she does our Tues Me Tuesday sessions, which are self-care sessions, where patients come together and chat about self-care tips and how to manage that type of thing as well. So I know that can be really helpful as well. So please, if you need us, we're here, just reach out. But if you do want to have specifically a chat about reasonable adjustments, I can certainly help with that.
The person I did the most for, I think, around really bad fatigue was somebody who worked irregular night shifts. Okay, so they would work some days and then some nights, and that was disaster in terms of the sleep pattern. And we dealt with the employer, and the employer said, we just didn't know and understand. And we hear and adapted. She went to a work pattern of working mornings, which is when people tend to feel better, and it just lifted the whole thing. And the employers are very nice, and they came back and said, that was so helpful for us because we didn't, and that's important. They don't know. They didn't know. Why would they? They didn't know, but they did listen, and they made adjustments. And as I said, everybody won with that.
And your work may also suggest a referral to occupational health. Yeah. Don't be worried about that either. I think people worry that that's them getting checked up on medically, getting sent to occupational health. It's not that at all. That's where hopefully your employer will learn a bit more about your condition through the occupational health department, and you can find out a bit more about what they can do to assist you.
Yes. So, and they're all over reasonable adjustments.
Yeah, brilliant. Thank you for
that.
That
completely.
Next question. As it appears that all manner of autoimmune conditions are so much more common in women of a certain age, not that I'm that certain age, what evidence is there that hormone levels are a trigger to set the immune system on the rampage, and could it be tamed by addressing this?
Oh gosh, as always, a very good question. So autoimmunity typically across the whole population is commoner in women than men, although that's not true of all conditions. So PSC, which is sort of PBC's evil cousin, if you like, is commoner in men than women. So it's not universally true, but in general, they're commoner in women. And PBC is the most skewed towards women of all autoimmune conditions, which is very interesting. So at 10 to 1, it's an outlier. So most of the others are around 2 to 1, 3 to 1, something like that. So why might this condition be? And the short answer is nobody knows. But we'll kind of rehearse it because it is very interesting. So why might it be? Well, it could be that something happens only in women that triggers the disease. So related to pregnancy, for example. Well, that clearly can't be the case, because you clearly get men who do have PBC, just aren't as many of them. So it isn't something that must be to do with women. It's just a lot more common. In terms of, and I like, I like to do a bit of detective work, and let's take a step back. So let's look at the age that people get PBC. So people get PBC usually probably start developing it in their 30s or 40s. Often it's younger than that, and increasingly we recognize that, but never in teenagers and younger, never. And there are people who say we've seen PBC in 10-year-olds, but we've looked at the information and it isn't that. So it occurs after puberty, typically in women, and very interestingly, it's a slightly more aggressive disease in premenopausal women. So it seems to be non-existent before puberty. It then has a phase where if you get it, it's less likely you get it, but if you get it, it's less likely to respond to treatment. And then after the menopause, it gets more common, but it's a lot milder. And those are quite distinct changes in the sort of natural history of it. And therefore, it kind of feels like it's got to be hormonal in some way for those reasons. So I think most of us would accept that. The other thing, of course, is that we get cholestasis in pregnancy, where you get bile duct tissues in pregnancy with huge, sort of sex hormone level changes. And of course, there are descriptions of people getting a sort of PBC-like liver disease with HRT and with the pill. Same sort of thing. That is not to say you mustn't take HRT with PBC. That is old-fashioned thinking. That is wrong. There is no worsening of PBC with HRT. It's a sort of separate thing that can happen occasionally with people. So it all kind of feels a bit hormony. So how might hormones, sort of cause it? I think there's a sort of general point, and then there's a specific point about PBC. So the general point is that the immune system is hormone responsive, and it has to be to cope with pregnancy. So when you're pregnant, the baby is more different to you than when you have a kidney transplant, okay? Because obviously half of the tissue type of the baby is the father's and half is yours, and yet you don't reject the baby, okay? So if you had a kidney with the same sort of gene types as a baby, it would be rejected in 24 hours. So it's a miracle of nature that the body can adapt that. And that's because when you get pregnant, there is this huge immune effect that suppresses immunity till the body learns to cope with the body. And that's all hormonally driven. The cells of the immune system recognize and respond to estrogen and progesterone, and that's how the effect happens, okay? And it's very powerful indeed. When you stop being pregnant, okay, then it reverts quickly, and that's a big shock to the immune system. That's why a lot of these conditions actually come on after you have a baby. And autoimmune hepatitis, for example, which is, another related condition, you can almost set your clock by people flaring up 6 weeks after they have a baby. We in fact book people into the clinic at 6 weeks after they have the baby, partly because the nurses want to see the babies, but that's the main reason, but partly because it's predictable, okay? It's nothing to worry about. It's because, you have this effect and then you get this reversal quite quickly. So it's well recognized. And in the 19th century, lupus, many people are familiar with lupus, untreatable as an immune condition, doctors used to recommend to people to get pregnant repeatedly because that was the only way to control the disease. It's extraordinary. And so people would have multiple pregnancies, and that was the way to control the disease until that, ran out of road as an option. So this hormonal change is kind of well recognized. In PBC, it's difficult to get a sense of it. We don't see enough pregnancies to get a real feel for it, but I suspect it will behave a little bit like autoimmune hepatitis. It gets better during pregnancy and it might get a little bit worse afterwards and then level out. So the effect of hormones on the immune system is probably a key, part of it all. Specifically in PBC, in autoimmunity, we talk about a target cell, okay? So you've got the immune response, you've got target cells. So for each individual immune system disease, it has its own target cell. So thyroid disease, it's the thyroid cells, yeah? So PBC, it's the bile duct cells. And unlike most other cells that are targets for autoimmunity, there are estrogen receptors on the biliary epithelial cells. So they directly respond to estrogen, okay? And I do wonder if that's part of it as well, is that there is and I wonder if that's implicated in cholestasis in pregnancy, is that actually the biology of the bile duct cells is affected by estrogens, okay? So those are two specific explanations. I think when people get PBC, premenopausally, I think it's a direct hormone effect. I think when people get PBC in their 80s, I think it's to do with the immune system perhaps behaving in a different way. So you have a more sophisticated immune system to cope with the need to be able to switch on and off. And I think that sometimes a little bit later in life becomes a bit inaccurate. So I think some of the milder PBCs we see in people a little bit later on are to do with the immune system kind of losing control. So all of you who've got PBC, women with PBC, you can console yourself. That's because you have a really sophisticated and advanced immune system, whereas we men have a simple and crude one. You can, use that however you want in your home environment. So it's to do with the nature of needing to be able to cope with pregnancy, because obviously we see people who've never been pregnant who get PBC. So I think there are two effects: the immune cells and also the cells lining the bile ducts. Now, as any of that information, the last point of the question is, how can we use that information? And a colleague of mine, who some people will have come across, called Professor Bassendine, Maggie Bassendine, is a great PBC person, and she published tamoxifen being given to people with PBC who happen to have breast cancer, not more common in PBC. Don't take this the wrong way, but it affects 1 in 12 of the population of women, so you're going to see it in 1 in 12 PBC patients. Tamoxifen normalizes liver function tests in PBC, okay, which would rather go with that argument that you can modify hormones and have that effect. And it's just at the beginning of the kind of obeticholic acid and elafibranor and seladelpar and all of that revolution of therapies. We were actually looking at giving a tamoxifen trial in PBC, but events kind of overtook it, and we got all of the new therapies. So it might be one of the things for the foundation to collect information on, because you'll have so many members who've taken hormonal treatments, either hormones or things that suppress hormones like tamoxifen, and actually collecting people's experience of that. So I have a feeling that tamoxifen, I'm not saying that we should give it for that reason, it has side effects, but it very clearly it was in people who had not normalized with urso, they normalized with tamoxifen. That's why it's good news.
We've actually had a question about HRT just came in on Facebook as well, so I'm going to just copy it into the chat here so you can read it, and then we'll read it out for everyone as well. So it's a question about a patient who started HRT 6 days ago. ALP has shot up from 172 in May to 193 today. Oral progesterone advice, they're a bit concerned. Yeah,
I would watch that. I don't think that needs watching. Anything other than watching, okay? So that's all still within the normal treatment range. I think, these numbers bounce around, okay? 100 to 300, 500, those are meaningful differences. So just take a step back with relatively small changes. So I would continue with that, but I would watch, and I would get those checked again in a few weeks' time. Okay. The thing about HRT is that it, I think as men in particular, need to thank Davina McCall for pointing out our many and manifest weaknesses in this area. That we, I think, doctors in general, perhaps male doctors, if you're going to be controversial, perhaps didn't see the value of this around the totality of symptoms that people experience. I don't think HRT specifically treats the symptoms of PBC, but it treats a component of a symptom set that people have. And if we can take 20% of the symptoms away, it doesn't really matter which 20% it is, because it's still 20% less. And I think we were guilty, if you like, of perhaps not talking about this enough. And it is one of the things that's important. We now have a specialist nurse in our clinic who's very wise, and it makes it easier for people to have those conversations. You know, she's a similar age to many of the patients, and it's just a much easier, natural conversation. I think with that, we've changed our practice. 172 to 193, I wouldn't really be worried about that. I'd want to see if it's a continued trend. I think if it goes above, you know, if it's a similar 20-point rise next time, then, you know, you just need to be aware of that. Of course, the other thing to do is to, if it does rise, and yet you're getting benefits from HRT, then a thing that's quite useful to do is then stop the HRT and then see if it reverts, because, you know, this could just be the disease, and you're putting 2 and 2 together to make 5. I have to say that problems with HRT are very uncommon, and so and that wouldn't particularly worry me. I don't think I've literally ever seen anybody with a significant deterioration with it, but, you know, it's the right thing to be aware of it. Obviously, you know, whether the HRT is worth continuing for anybody is kind of to do with how you feel on it. I mean, it's a, you know, and if you can't detect any difference, then, you know, in terms of how you feel, then it's actually probably not worth taking it. So it really is how much you think. The one thing we wouldn't do is use HRT for bone protection for osteoporosis. We used to do that a long time ago. There are much better ways of protecting your bones with fewer side effects. So we wouldn't use HRT for that. But I wouldn't be worried up front about those numbers. I'd file it away, get them checked in a few weeks' time, and then see what it looks like. And then if there is still a concern, stop it for a length of time, check that returns to normal. And if it goes up on the drug, and then this is how you look at all drug liver reactions, by the way. If it goes, it's one thing it going up on the drug, but you then have to see it come down off the drug. Otherwise, it's a coincidence. Okay.
Great, thank you. We've actually got a question about a hysterectomy, which I'm going to pop in the chat again here for you to read, and I'll read it out for everyone else as well. So we've got a patient who's commented that they're a younger person with PBC and then endometritis. They're having a hysterectomy soon for endometritis, and could the hysterectomy potentially also help with their PBC? They're leaving her ovaries in place due to her age.
Yeah, I mean, in a sense, you know, it depends on, I mean, this is all critically dependent on age. In a sense, you know, up to about the age of 50, physiologically, you need to have, as a woman, you need estrogen and progesterone, because otherwise you get problems without it. And there are 2 ways you can do that with a hysterectomy. One is to leave the ovaries in place, which will still continue to produce hormones, or you can take the hormones, you know, as an artificial replacement, but you need one or the other. So it's probably, you know, each way. And I don't think any of us would advocate, you know, removing ovaries as a treatment for PBC. The point about these discussions are to get you thinking and to understand, you know, and I don't think we would go down that. I mean, I think, you know, endometriosis is a horrible condition. I don't have to tell anybody that. And of course, remember, my symptom burden thing is very important. So pain, stopping you sleep, knock-on effects the next day, the pile of problems, which is how you feel, as I said, it doesn't matter, you know, if you have something that's 20% of that, it doesn't matter whether it's a PBC thing or something else, it's 20% off the pile. And actually what you may well find is that removing a driver for discomfort like that actually has a knock-on effect in terms of general coping with symptoms and things. So that's why we're so hot on treating other symptoms, you know, bony pain and things like that, because that might be the easiest thing to treat. The PBC fatigue might be difficult, but the other things might benefit. So I think the benefit will come from the hysterectomy and reduction of the symptoms related to the endometriosis. I think it wouldn't matter one way or the other about, you know, hormone replacement or ovaries in place. That's out of my kind of knowledge zone, but you will need one or the other unless you're, you know, heading up towards the 50s.
Great, thank you. We've got a question about Urso that's come in on Facebook, and it's asking that patients just started Urso and asked if it causes itching. They're only diagnosed this week, haven't found out what stage I'm at yet, but never itched before. Until last night, and this morning was itching all over. So it seems to be coinciding with her starting Urso, she started to itch.
Absolutely is the short answer. About 1 in 20 people starting Urso will get itch with it. Okay, so everyone's very familiar, a lot of people will be familiar with itch with obeticholic acid. So obviously itch is part of PBC for some people, not all, and it's very characteristic itch. So it's very easy to work out if it's a PBC itch. It's very characteristic, the depth under the skin, that sense of wanting to take the top of the skin off. It's usually, it's difficult to mistake it for something else. Obeticholic acid will cause itch, and people had a lot of questions as didn't really understand why that was. Was it because it was a bile acid? Was a theory that was a current one? And of course, that's a factor we build into managing obeticholic acid. People forget, though, you get exactly the same effect with urso. It's one of the reasons people can't take urso. There are basically 3 problems you get with urso, 4 problems you get with urso. So one is this itch, about 1 in 20 people. One is the GI disturbance, the sickliness and the loose stool. Third is a bit of weight gain. And then the 4th is hair loss. Okay, although who am I to talk about that? If only I had a hat to wear to cover that up. So those are the things that urso can do. They're usually not deal breakers. They're kind of nuisance things rather than anything else. But I have seen people with quite significant itch with urso. Okay, and it's probably because it's a bile acid and therefore mimics the natural itch. So what would I do? Urso, the world has changed with the advent of other therapies, and I would not put up with chronic itch with urso because there are now alternatives to it. You're just one of the people who can't take it, and that's the end of it. Now, if it's really recent onset, it may settle down. Okay, it may settle down. So it's early days. These things have a habit of settling out. But if it doesn't do that, then don't just persevere with it, because there are other alternatives now. And I think this will increasingly be what we think you do. I mean, urso is important, but it's not a miracle drug, and there are other alternatives. So all of the new treatments, elafibranor, seladelpar, and obeticholic acid, are all licensed for second-line therapy in people with inadequate response to urso, which is the way we tend to think of them, but also for people who can't tolerate urso. Okay, so they're all legitimate treatments to give to somebody who can't, as an alternative to urso, who can't take urso. Okay. Now, the one which I wouldn't use is obeticholic acid for obvious reasons, because if you itch with urso, you're very likely to itch with obeticholic acid. So I would go for elafibranor or seladelpar. These are coming very shortly to the UK. Elafibranor will be the first. There is what's called an early access program going now. We are starting our first patients in Newcastle on this drug, and it's a bit of a clunky process, so it's going through the whole licensing process, but these are now available and will be available, and they work a treat in people with itch. So I think that will be no-brainer. Elafibranor or seladelpar for somebody who can't tolerate urso because of itch, and avoid obeticholic acid. And it's just one of those things. And do not listen to any doctors who tell you that itch is made better by urso. It is made better by some people. Their itch gets better. A lot of people, it makes no difference one way or the other, and a small number of people it gets worse. And that's just the nature of the beast.
We actually have a similar question about urso. Hello, my doctor is stopping my urso and starting fenofibrate. Is this a new protocol?
So essentially, we have 5 therapies that we use in PBC at the moment. And if you look at the history of PBC, I've become terribly, reminiscing about, the old days. You're all bored of, it's a bit like Keir Starmer's father was a toolmaker. I keep trotting the same stories out. Sorry, that wasn't meant to be a political point. We don't do politics. So I tell everybody I did my first PBC clinic in 1991, and you see this, this incredible, and there will be people around who were patients then. I'm still seeing patients I first saw in 1991. And I think we all need to take a step back and realise the quite extraordinary progress in this disease. And I think for those who've had the long view, Mo, you must have been incredibly young in 1991.
I was 20 in 1991.
Okay, see. progress is extraordinary in so many ways, about recognition of it, recognition of the symptoms, patient support groups, the advent of therapies. You know, we literally had nothing other than come back when you've got cirrhosis and complications and we'll see what we can do. It's changed out of all recognition. I think we sometimes, you know, worry about things, but the big picture is extraordinary. And of course, you know, when you talk to people in the PSC community where they still have no therapy, you know, we realize how fortunate, you know, whether it, I don't know if it's fortune or whatever, you know, as Gary Player said, the harder we work, the luckier I get, you know, there is an element of that to it all, but you know, we are in a good place. But a big part of this is 5 treatments. Urso, then we had bezafibrate and fenofibrate, which were the beginnings of second-line therapy, although we didn't really know that at the time. And those aren't licensed for use in PBC, but they are quite widely used, and we've got lots of people who've been on those for a long period of time. And then we had obeticholic acid as the first designer second-line therapy for PBC, and then elafibranor and seladelpar, which are the second wave of designer therapies. That's the history of it all. So in 2024, we would not tend to start people on bezafibrate or fenofibrate. Okay, why not? Because there are better drugs now, and no, maybe for a year until, say, elafibranor or seladelpar become widely available. But elafibranor or seladelpar are more effective, better understood, better studies, and licensed versions of bezafibrate and fenofibrate. So those drugs were always a stopgap until definitive treatments came along, but that's now happened. So we have plenty of people on fenofibrate. I'm not sure I would start anybody on it. We have some people we have a lot of people on bezafibrate. I'm not sure I would start people on it for second line therapy. Now the caveat is both bezafibrate and fenofibrate are actually very useful for treating itch. And so where people have got itch as a problem, then actually none of those other drugs are actually approved. You know, obeticholic acid you wouldn't give somebody itch anyway, but elafibranor and seladelpar actually are not available for just treating itch. It's for second line treatment. So fenofibrate and bezafibrate will continue to have a use with that. And also, we are convinced, I'm completely convinced, that the definitive approach to treatment will be a combination of therapies. So it will be urso plus obeticholic acid plus bezafibrate or elafibranor or seladelpar. I think we're then going to be into the realms of curing PBC. I really do. So the question with somebody off urso and onto fenofibrate is why? What's the rationale behind it? If it's poor tolerance of urso, that's fine, but I'd want to be, you know, looking at one of the other therapies in a fixed period of time. If it's for itch management, that's fine. They're perfectly reasonable things to do with it. So it's not, I don't think I've ever used fenofibrate rather than urso in somebody, but I could envisage a situation in which I would. So I think the question is, what's the rationale for it? One question, can I just ask myself a question? Is that all right? Yes. So the question I'm going to ask myself is, PBC Rockstar, please guide me. I'm on bezafibrate and have been for 20 years with normal liver function tests. Am I going to need to stop this and take one of the new drugs? Okay. And if I was asked that question, I would say that's a really good question. And it's one that's going to crop up again and again and again. And my clear answer is, if it ain't broke, don't fix it. So it's like urso dose. You'll be aware that we use 13 to 15 milligrams per kilogram. Okay. And that's the right dose. There are plenty of people out there taking 8 milligrams per kilogram. Okay. And have done for 20 years and have completely normal liver blood tests. Now, why would we increase the dose when you've got all the response that you want? So there's a difference sometimes between what you would do newly now in somebody just presenting versus reversing what you did in the past, given that you might well know that what you did in the past actually worked for that person. So don't be dogmatic about it. And if I had somebody, I mean, we're gearing up for this, somebody comes along on bezafibrate and, and says, I'm fine, got no itch, my blood tests are normal, do I need to swap? Absolutely not. Why would you? You just bear it in mind. If you need a swap in the future, you've got options, but don't, if it ain't broke, don't fix it. Don't go. One of the things I always say to, the fellows and the registrars in the clinic, the younger members of the band, if you like, I'll stop it, it's gone too far, is don't fiddle, okay? This is the biggest piece of advice with PBC. If you've reached a nice equilibrium, okay, if everything's going well, do not fiddle. Don't change the dose, don't change the drug, don't fiddle, because all that does, what can you gain from it and what can you lose from it? And people's bodies get used to particular treatments. This is why there is a real issue actually about generic treatments. And it's well known in the world of inhalers for asthma that a different manufacturer's inhaler can if you change, can lead to a loss of control. So we get used to the therapies that we take, and if you found what works, then as much as you can possibly do, stick with it. So we will not be, anybody who wants to swap is welcome to, but we will not be doing it as a wholesale thing, because I'd have to be able to explain to people how they would benefit from it, and if they're not going to benefit, why do it? Okay.
Yeah, that's great, thank you. Question here about fatty liver. Is it common for someone with PBC to have fatty liver?
You've said the words we don't talk about. We don't talk about fatty liver. Okay. So fatty liver, okay, goes under a number of different names. Non-alcoholic fatty liver disease is one of the old names. NASH, non-alcoholic steatohepatitis. And they've now, imitation is the sincerest form of flattery, actually. So they've now changed the name in the disease with one mistake. So, and the reason why they changed the name is that defining something by what it isn't helpful, okay? And defining something by it not being alcohol isn't helpful, because it then includes the word alcohol, right? So there was a strong rationale for changing the name, rather like there was with PBC, because people, the word cirrhosis was incorrect and wasn't helpful, okay? So what they did is change it to MASLD, which is metabolic associated steatotic liver disease. And the mistake they made is MASLD just doesn't sound sensible to me. And the other is, of course, they've changed the abbreviation. So when somebody says MASLD, they say, what's that? And they'll say it's non-alcoholic fatty liver disease, and therefore you've used the word, the alcohol word, when you were trying to avoid it. So I wouldn't have done that. I understand why they did it, okay? So this comes about because of an imbalance of energy going in and energy being consumed. So, energy goes in terms of food, energy goes out in terms of being burnt up to power the body. And the extent to which you utilize energy is genetically controlled. So, how efficient your energy production is genetically determined, and those genes that predispose to you accumulating fat are the same ones that predispose to type 2 diabetes, okay? So where people do store a lot of fat, it's actually a genetic modification of benefit, but it developed in our population in days when you had to go along and hunt down your own food. Okay, so if you were going to have to hunt a gazelle to eat, it was useful for you to get the most benefit you possibly could out of one gazelle. Whereas if you just wasted it, you have to go and catch another one. So actually this hoarding, these genes around hoarding food were a genetic advance in populations where food was limited. The problem is in a world of Tesco's, and pick and mix stalls, food is not limited. So that's why they are in the population, and that's why they're a problem. So if you have these genes, you will tend to accumulate fat in the liver, and that fat can contribute to inflammation and liver injury, we now understand. There is no connection between PBC and fatty liver disease, okay? So fatty liver disease is no more or less common in people with PBC than it is in the general population. So that's important to say. It, however, can confuse everybody, because you'll have, usually it will be somebody has an AMA and they also then have an ultrasound that says fatty liver. So is it PBC or is it fatty liver disease? In truth, it's almost always both. Okay, and so, you know, in a sense, people don't need to scratch their heads around it. If the ultrasound says fat and the antibody says PBC, it's probably both, and you need to be aware of that. Which is the dominant one, you won't be able to tell from that. But there is another interaction, two interactions which are important. So one is urso is a good treatment for both of them. So although we use it obviously for PBC, it has been trialed as a treatment for fatty liver disease. So if you're not sure if it's fatty liver disease or PBC, give people urso, because it will work for both of them. So that's important. And then the other one is that if there is a component of both of them are conditions that are associated with fatigue. Okay. They're both associated with fatigue. So the fatty liver disease community don't tend to really think about this and in the way that we do, but there are a lot of similarities between it. So they can be additive in that regard. Fatty liver disease has no, or didn't have any licensed therapies until very recently, with the approval of a drug called resmetirom, which is not desperately effective if you look at the figures. So it's early days about specific therapy for fatty liver disease. I think if you have got fat in your liver, you've got PBC, then I think steps to reduce that fat in the liver is quite valuable, because it is part of the pathway of type 2 diabetes, which you don't want. And so therefore, watching your food intake and dieting and exercising are the ways to do that. There's a whole literature around that. And one of the things that is creating quite a lot of interest at the moment is you'll be very aware of the soup and shake diet for type 2 diabetes. That is also very effective for fatty liver disease. And for those people who think that's a real innovation in healthcare, which it is, I am in fact responsible for that being invented, because one of my colleagues here called Roy Taylor, that people may have heard of and come across, he came into my office and said, I've got this really good idea and nobody will fund it, about reducing fat in the pancreas and treating diabetes, and here's the evidence. And I said, I was his head of department, I said, Roy, that's a really good idea. We'll give you £10,000, show us if it works or not. So for anybody who's benefited from that, that's yet another reason to thank me. So you can thank me for my knowledge about PBC, my fatty liver disease, and my impeccable collection of greatest hits albums.
I'm not quite sure what to say to that. Right, just you touched on fatigue there actually, and we do have a question about fatigue. We've got a patient asking if there's any reason why the mornings for them are really bad with their fatigue. It does affect them the rest of the day and in the evening too, but mornings are certainly the worst.
Yeah, so that's unusual. It's usually the way around. It's usually the mornings are better, and then people run out of energy throughout the day. However, that's an approximate, that's a generalization, like so many of these things are. And so it is what it is with you as an individual. If I had somebody who was very clear it was worse in the morning and then it gets better during the day, I would doubly look for other causes of fatigue. So it's in a standard part of our approach that we use. Look for other things that happen. Look for other things that can be causing fatigue, which might be associated with PBC or might be common in the population. You know, obviously we talk about itch, PBC patients, anemia. There are lots of causes why PBC patients get anemia. Thyroid disease we talked about. Three things that specifically are worse in the morning rather and get better during the day is that's the pattern that you most commonly see with chronic fatigue syndrome. Actually, it's one of the big differences with PBC, for reasons people don't really understand. And also it can be a feature of depression, it can be a feature of long COVID. So they behave in a slightly different way. So if it's somebody who's really definitely got PBC and it's PBC fatigue and it's worse in the morning, I would look at sleep. Because that's the direct connection, because sleep is part of fatigue in most PBC patients. And I've said on these calls many times before that almost nobody who sleeps normally with PBC has fatigue, and almost everybody with fatigue has sleep abnormality, right? So it's some way it's connected, and we're starting to look at that and the ways we can treat that and use that. There is a very direct connection if people are really sleeping badly with, you know, we would know in our world, if you have a really bad night on call, you're absolutely wasted the next day. So there is a sort of direct connection. And the one to look out for with that is obviously itch at night, because that's the way you can have devastatingly bad itch. So fatigue is what it is to the individual that it is. And as people will know from these, you have a mixture of what we call central fatigue, brain-driven fatigue, peripheral fatigue, which is and certainly, peripheral fatigue, where the energy runs out in the muscles. That's a classic, getting worse later in the day. If it's more central, it's more about brain function, and that brain function's been, slowed down by poor sleep. That's probably what's going on. So it would slightly, give us a nuance as to, which place you would look and what you would do.
Brilliant, thank you. We've got a question from a patient who's asked, a new consultant has stated that patients with PBC have a high risk of cardiovascular disease. They haven't heard this before. Is this the case?
No. No. It's been looked at to the nth degree. It's an obvious question, and it's been looked at because of the raise in cholesterol. Okay. The elevated cholesterol levels make people think about it. But there have been lots and lots of studies that show that PBC is not protective and PBC is not at risk of heart disease. It is interesting. There's an awareness in medicine at the moment that this assumption that women don't get heart disease and men do is incorrect. It's just that women with heart disease seem to get ignored. So women do get heart disease, and women are more likely to smoke now than men, for example. And so there is a reason around it, but that is independent of PBC. And I don't know why they're saying that, because it's kind of not true, really. I mean, it might be people putting 2 and 2 together and making 5. In terms of PBC, what is associated with it is other autoimmune conditions, essentially, as we discussed before. And then that's it. There's no cancer association. There's no heart disease association. A lot of people worry with the kind of brain fog about a dementia link. There's no dementia association. It's actually pretty straightforward, other than other autoimmune conditions. Now, having said all of that, if your parents both died of heart disease in their 40s, then that's your risk factor, not having PBC. And so we certainly do advocate investigating and managing people's hearts with PBC, but it's not specifically linked with their PBC. I cannot remember, because we were just wondering about this. I can't remember the last time any of our patients had a heart attack, for example, and we have about 1,000 patients. So I know that's a little bit shonky information.
Thank you. We touched on this earlier when you mentioned about Urzo causing weight gain. We've got a couple of weight-related questions. So just in general, a wee bit more information on Urzo contributing to weight gain.
Yeah, so it's Keith Lindor. You'll know, a lot of people will be familiar with his name. One of the fathers of PBC study, and he still going strong. Must be in his 80s now. Extraordinarily nice man. A real gentleman who really got and understood PBC patients. He's the one who set the clinic up at the Mayo Clinic, which was one of the founding clinics of PBC, and did phenomenally good work, and is a friend of the PBC community. So he published this about an average of 2 to 3 kilos weight gain, so about a quarter to half a stone for everybody starting Urso. So I think it's a real thing. Why does it happen? I think it's really simple and actually a little bit boring, which is that when you have PBC, because of the bile acid abnormalities, you become inefficient at absorbing fat. So in the old days, we used to see people lose weight with PBC. So particularly back in the early 90s, we'd often it was not uncommonly you'd see tiny little ladies, people with 4 or 5 stone, with real struggle to put weight on. That used to be something you saw. We don't see that anymore. And that was part of the chronic process in PBC, because you didn't produce enough bile acids ultimately because of the bile duct effects. So therefore you didn't have the bile acids in your gut, you couldn't absorb fat, so you couldn't take nutrition in, so people lost weight. So we used to see that. And of course, because you need bile acids, otherwise you can't absorb fat. And actually that's why you'd get loose stools, you know, because the fat would then go through the bowel as if you had malabsorption. That would cause it all. When you take an urso tablet, of course, that's a bile acid. So although we're giving it for a different reason, actually it will also help you absorb your food because it replaces the bile acids that aren't there. So sadly, urso returns your digestion to normal. But in the meantime, your body had got used to running on less in the way of fat because less was being absorbed. So it's unfortunate. It's a bit similar reason why people put weight on. One of the reasons people put weight on after a transplant is because unfortunately your body was giving you a bit of an assistance in losing weight by not absorbing your fat. It was a bit like Xenocal, which is a treatment that people use for weight loss. So it's to do with a normalization of biology. So it's not a side effect, it's actually part of the normalization. So just be aware of it and just be doubly careful about, you know, the amount of food you're taking in. Because of course, with the fatigue, people struggle with the exercise side of the equation. So it's true. It's one of those things. It's not a reason not to take urso because there are going to be other, you know, bigger impacts down the line. But it's actually this, you know, one of the, personally, I think that there are two things we don't see anymore, or don't see anywhere near the level we used to, because of unexpected benefits of urso. One is this lack of seeing malabsorption, and the other is I'm convinced it's helped with osteoporosis. So, you know, we could do DEXA scans on everybody, and we rarely see osteoporosis these days. The average number of fractures when I started was 9 per person, 9 fractures. We just don't see that anymore. And I think it's to do with urso helping you absorb vitamin D and helping normalize that. And it's a benefit we don't tend to think of, but I'm convinced it's one of those things that has absolutely changed.
That's great, thank you. I know we're getting close to time, but we've had this question quite a lot recently, and just because of the new treatments that are available. So just as we were talking about weight gain there, so we've had someone ask about the new weight loss injections that are now available. So specifically, they've mentioned Wegovy and Manjaro, but they're all of a similar nature. So just what your thoughts are on that, and if there's any, if there should be any worry in connection with you having PBC if you're thinking about it.
Yeah, I mean, you'll find that I know people who've looked at this, and liver disease is an exclusion for them. So I think now, I mean, ironically, they are used as a treatment for fatty liver disease. So it's one of those bizarre situations where it is both the reason to use the drug and the reason not to use the drug at the same time. And we do see that, you know, with urso-oxalic acid, because some of the manufacturers say it's contraindicated in liver disease, which is actually the only reason we use it. So do I think that there is a problem with Wegovy and PBC? No. I think Wegovy has its actions not through the liver, and it has a very benign safety profile in fatty liver disease. Phil Newsom from Birmingham, who's many people will have come across, did the trial of that. I think it looks very effective. So I don't think there is a problem, but I do know where people have gone to explore this. They've been told, because you have chronic liver disease by definition, PBC is a chronic liver disease, you can't get it. So I think that whether that's a sensible restriction or not, I think it's one of these ones that's a precautionary one. So remember, there are certain pretty much every treatment says avoiding liver disease, avoiding pregnancy, avoiding this, that, and the other. And actually only a vanishingly small number of them have any evidence whatsoever that they're a problem in that setting. But what we lack is evidence that there isn't a problem. And it's very difficult to prove a negative. And so, you know, like urso and pregnancy is the classic example, because the prescribing information for urso says avoiding pregnancy, and that's not because it causes any problems in pregnancy, it's because there's no evidence, except we use urso in cholestasis of pregnancy. So actually there are people who are pregnant for whom the right treatment is urso, but that treatment is contraindicated because they're pregnant. So it's part of the madness we slightly have to put up with. So I wouldn't, I mean, the one that is not contraindicated is bariatric surgery in its various different forms. And you know, Wegovy in a way is a kind of longer term kind of chronic version of that. I have encountered a number of PBC patients who've had bariatric surgery in its various different forms, and they've done very well. It's a no-no if you've got cirrhosis, okay, because of the blood pressure changes you get with it. But in non-cirrhotic disease, it's absolutely straightforward. Remember, they do it in people with fatty liver disease, and PBC patients have much better livers than fatty liver disease patients. I think Wegovy is the kind of, us in the rock business know that you can be the flavour of the month and then you go out of fashion, although I've clearly never been out of fashion. I think Wegovy is a bit of a flash in the pan, okay? I think everyone thinks it's brilliant, but actually the idea of it is brilliant. The reality isn't quite so good. So I suspect we're in peak Wegovy, and I think we'll overshoot backwards and look at other, the number of people who I took Wegovy but, and then the but is always very interesting.
Okay. Oh, thank you. I appreciate that. That's us for today. So I know that's gone in really quick again. So thanks to everyone who submitted questions. There are some questions on Facebook that I didn't get to, but I'll make sure those are added into our session for next time. And I'd also just remember that I'll upload these, all these sessions get uploaded onto our YouTube channel as well. There was a question on Facebook about diet and PBC, and I just wanted to say that from the PBC conference last year, there is a great video up on our YouTube channel about that as well. So I'll pop the link into Facebook for that later so that people can go on and view that. And unfortunately, I will share the news that Professor Jones is not joining us for the conference this year, which is a real shame. Someone's asked in the comments there about a taster at the conference. So you're not able to join us this year, but I think we should be able to have... Sorry?
The reason is because I'll be in America. Not on tour. As people will know, we are mired in the regulatory stuff around the drugs. Now, this is about obeticholic acid, and it is not about whether this drug works. It's very clear in the experience that we all have that this drug works. I mean, there'll be people on this call who can tell you it works because of their own experience of it. It is also perfectly safe. There'll be plenty of people on this call, and like all of these drugs, they're powerful, right? You've got a significant illness, they're powerful drugs. It's not a surprise, and you have to be careful and thoughtful in what you do. But we are, and that's what we do. The problem is what evidence people regard as acceptable, and the extent to which people choose to disregard other evidence, and that's the real problem, because the experience of thousands of patients doesn't count compared to a particular study that you want done in a particular way. But you can't do it in that particular way. It doesn't exist. Okay. So it's it's absurd if you take a step back. I mean, it is Kafkaesque in many ways. That's a term that I've started using quite a lot. So it's really important that we continue to have access to obeticholic acid, but it's doubly important because exactly the same problems will befall elafibranor and seladelpar, because they're going to have just the same challenges doing a clinical trial to a hard endpoint. I mean, as I keep saying to you, and Robert is very vocal on this absolutely correctly, if I was to invite somebody who was at increased risk of dying of PBC, because that's the people they wanted in the trials, and I invited them to go into a trial for 6 years to take obeticholic acid or a dummy tablet, and then come for lots of clinic visits that are not strictly necessary, and then at the end of it, it's whether you've died or not is the outcome measure. Or alternatively, you could pick up a prescription for obeticholic acid on the way out. What would you do? Okay. And this is what I've been trying to say to regulators is, what would you do? What would you recommend to a member of your family? And they've said things to me like, well, you should make people go into trials. Hello. Have you heard of ethics? Have you heard of the law? Have you heard of, all of those things? What planet are you guys on? You cannot expect sensible people who understand their disease to be identified for a trial, to be given the option to go into a trial against placebo when that drug is available to them. It's insane. And of course, exactly the same things will happen with elephant, and they're all gearing up to do those trials. And we've told them, don't bother, you can't do it. I mean, and Robert was talking about a strike of placebo-controlled trials in these things. And I don't think that's a bad idea, to be honest, because how many times do we need to give people a dummy treatment and work out that nothing happens to them good? I mean, we know that. And so it's trying to get that across. I'll tell you a factoid, okay, that was buried. So the end of this point is I'm in America for the FDA hearing about whether ochre is still available in America, which will guide what happens around the rest of the world. So that's where I am, which is...
You're away fighting the fight for us. Yes, you are.
Sorry?
You're away fighting the fight for us.
Oh boy, I'm away fighting the fight, and it's a fight. But buried away, when you get an official document from the FDA or somewhere like that, you get a big document, and then you get a whole load of additional information in appendices, right? And the first place you go and have a look is the appendices, because that's where they bury things they don't want you to look at, because they assume nobody reads the appendices, okay? So it's where I go first, because I'm cynical like that. Think of it as the bonus tracks on my album. So I went straight into the appendices to see what I could find there. And the basic problem with obeticholic acid is that confirmatory trial, 6 years in people at high risk, people had no benefit when they were taking the drug compared to people in the placebo group, okay? Therefore, the drug doesn't work, therefore it comes off the market, okay? However, we've got lots of evidence from lots of use in clinical practice that clearly shows benefits, so there's something funny going on. When you go into this appendix, you find the following information, which I didn't know. Thank you, the FDA, for pointing it out. Is that when you look at people in the placebo group, okay, placebo group weren't taking ochre, there were derivatives of either ochre or bezafibrate in 80% of the people. 80% had taken either bezafibrate or obeticholic acid outside the trial. Why? Because they didn't want to put themselves at risk, because they were sensible, normal human beings making a rational decision, and they weren't telling people because they knew they'd get shouted at, right? So 80%. So if you want to go have another protest in Brussels, this is what you need to say. That trial showed no benefit because 100% of people in the active drug were taking it and 80% the other ones. So there is no difference in the people, okay? And do you know what the FDA's explanation for this is? I find it quite extraordinary, okay? It wasn't very much obeticholic acid, so it probably wouldn't have had an effect. Now, if you went to the Olympics and had a little bit of steroid in your blood, they would say you're banned for the next 4 years. And you'd say, it's only a little bit, it's not very much. But they would say, but it shows you've been taking it. And so therefore, you might have been taking more of it, or you might have been doing it, you know, you've crossed a line. Whenever people are arguing about this, 80% of people in that trial took obeticholic acid or bezafibrate when they knew they were in the placebo group. And that just explains why you can't do the trials. It does not mean the drug doesn't work. In fact, both groups of people, the oddity of, in fact, can I show, am I allowed to share? Can we share things on this?
Yeah, you should be able to share your screen, yeah.
Right. Oh God, this is an experiment we've never done.
You're going rogue and I'm a wee bit worried about it.
How do I show a picture?
If you bring the picture up on your screen and then use the icon at the bottom of the screen that you see that's got 2 screens on it, it'll be red just now next.
And you've gone all IT-ish on me because you're an IT person, you understand these things. Right. Let me, I just want to show you something, right? Now I've brought it up. How do I share it?
The button on the bottom that's next to the microphone one, the red, well, it'll be red at the moment. It's got 2 screens with a line through it. If you click on that, it should let you share.
Oh, hang on. Isn't that clever? Can you see it?
We can see it, yeah.
Forgive me for running on, but this is really important, okay? So this is the data from the Cobalt trial. So this is the trial that showed no benefit for people taking obeticholic acid compared to placebo. Okay. Yeah. And compared in this is with a group of people in America from a health database called Komodo. So obviously in America, they do insurance claims. And so you can track what's happened to people by the insurance claims that they make. So this is what we would call real world evidence. So the Cobalt group are the people in the trial. The Komodo are many thousands of people in America. with PBC who are treated in one way or another for their PBC. And what you do is you take those people and you match them by every characteristic, age, sex, duration of disease, everything you can imagine, so that they look the same. Okay. And essentially, this is the data. So I'll explain what it shows, right? So the first thing to see is hidden under here is a blackish line, and the blue is a blue line. The blue line is people, what happened to people. So this is the likelihood of still being alive at a certain point in time. In the Cobalt trial, that's the blue people, right? So at 6 years, 75% of people are alive without a transplant, right? So that's what happens to people of the severity to go into the trial who take OCA. But look at the black line, it's identical, literally identical. And that's what happens to people in the American population who take obeticholic acid, okay, not in the trial. So what that shows us is that the people in the trial are just the same as the people not in the trial if both are taking obeticholic acid and we've matched them. So one is representative of the other, right? Mm-hmm. Yeah. Now look at the red, okay? The red, the lower one, is the Komodo group of people who weren't given obeticholic acid, even though they could have been, okay? These are the people who weren't treated. And very clearly, there is a massive difference between those and the black line, right? So this is the benefit of obeticholic acid in real world evidence, right? If you look at the Komodo treated group, sorry, the Cobalt people who took OCA, which is the blue ones, with the Cobalt people that, quotes, didn't take OCA, they're almost the same. They're not quite the same, but they're almost the same. But we know that 80% of people took the treatment. So that line is almost like that one because they're the same. But if you look at this group of people who are notionally identical to this group of people, one is a group of people who don't take obeticholic acid in the trial. The other is an identical group of people who don't take obeticholic acid in real life. The biggest difference you see is between two identical groups of people. Okay, these are the same. They're the same people. I mean, they're the same. They haven't taken the drug technically, and they are the same in terms of their severity. And yet, if you saw this as an outcome in a trial, you would say the drug up here was effective, and that one isn't. And the only explanation you can have for that is that that group have stopped being that group and have become that group by taking the treatment. Yeah, and there, in a nutshell, is what it's all about, is that you cannot possibly tell anything from this because those people do not look like people in the real world who are just the same as them and who don't take the drug. Therefore, they're taking the drug. And hopefully you will all understand that here, but the regulators don't understand it. You tell me another explanation for that, that explanation. Does that make sense?
Yeah, it does, absolutely, yeah.
It's absolutely mad. So all of the debate, all of the argument is about this drug doesn't work because that gap's not very good, ignoring that gap, when in fact the true difference is between that and that, which is very substantial. So in real life, if with the same max severity of disease, you have a 75% chance of being alive free of a transplant if you take OCA, and with exactly the same disease, you have about a 40% chance of being alive without transplant. And this is a drug that they tell us doesn't work. Okay.
Yeah. Yeah.
And I don't know how much simpler I can make this to try and explain this to people, but this is the drug they want to stop because it doesn't do anything to benefit people. And this is long before you look at all of the test improvements and all the changes that people are familiar with. Mm-hmm. And it's regulation gone mad, and we need to push back a bit. But that's why I'm not at the conference. But I do apologise. Who's going to be there, Mo?
George Mills is joining us for the whole weekend, and we've got physiotherapists from Palak Trivedi's clinic joining us as well.
Oh, nice, good.
About their study that they're doing. We've got our occupational therapist returning to do some sessions with us as Fantastic. Well. Self-care from Robert and Cheryl, and myself and Linda on hand as well. So we're really looking forward to it. I would just like to say, if you want to just stop sharing your screen there, actually, Professor, that'll put us back on. There we go. So I also just wanted to say as well, we're in the final stages. It's a week on Saturday that the conference is. There's recently one room become available at the hotel. So if anyone is interested, please reach out to us. Registration is still open. There's also some day delegate spots if people want to come and join us in person, but not stay at the hotel. And there is, of course, the virtual option to join us as well. Not all sessions will be available virtually, but we're trying to make as many possible that are available virtually as well. So the agenda is looking great. You can look at the agenda on the website as well. And also just a quick update as well. We've got International PBC Day a week on Sunday. Our campaign this year is Provide Better Care, PBC. And that's all about ensuring that patients are looked after and that the amount of care that they get in relation to not just looking after the biochemistry, but also patient symptoms in that as well. And that was very much a topic at EASL this year as well, around making sure patients are asked about their symptoms and those are helped to manage as well. So keep an eye on our socials. There'll be some stuff launching today for that.
I've just decided what my band should be called. It should be the Bald Eagles, shouldn't it? The Bald Eagles. There you go.
There's a couple of comments, and I know I shouldn't encourage you, but I need to share these couple of comments. So there's lots of comments about good luck with the FDA. So we know that while we're here having our conference, you're away fighting the fight for us. And Robert's also going out as well at one point over that time as well to be available for the FDA. There's comments about the band going into international. And that you're hilarious, but I'm obviously just making things worse because this me telling you that, but they did really make me smile. So thank you so much.
Caroline put a comment. Surely all placebo trials have to change a different way as needed. I couldn't agree more. That we have to find a different way, and we've got to move away from arcane arguments about particular ways of doing things. What we should be doing is looking for the truth. Okay, we should be looking for the truth, and the truth is always complicated. And they want a trial that gives you a clear-cut answer, but unfortunately, with diseases like this, it doesn't. And I know that the companies who make elafibranor or sel-dalpa are really worried about this because they'll get caught in all of this. These drugs are fantastic. We are and here we all are. We are at the beginning of. We've now, suddenly got two brand new drugs with a very clear mode of action benefit for people. They look really straightforward to use. They're going to revolutionize what we do. And yet all we can talk about is losing drugs. It's mad. It's just mad.
Yeah. So, and that's what we have to do is keep fighting. And it is I think the really important part of it is we're not looking at a safety issue here. It is a problem with
no, absolutely not. These drugs there was, with obeticholic acid in America in the early days, it was used in a very gung-ho fashion that we never did in the UK, to do with how we do things. They used it in people who should never have been treated with it and who needed to go for transplant, and those people got worse, as in fact they would do with all of these drugs. They do with antivirals and hepatitis C. It's a well-known fact in hepatology. And that was a mistake. We've learned from that mistake. Nobody sees that anymore. We now know with a brand new drug in a brand new way, we as doctors have to do a best guess of how to use them. And then we have to learn. And the whole point about any issues with healthcare is problems arise when people don't learn for the future. And we learned something about all of that, but we seem to want to then just pretend we haven't learned it and go back to pointing out that there's a problem. Yeah, but there's also a solution, and actually a problem with a solution ceases to be a problem.
Mm-hmm. No, thank you. And we do appreciate everything you do for us. And thank you again for joining us, and we'll be seeing you again soon.
Oh, can I just say one more thing? Sorry, you'll tell me to shut up in a second. You cut me off soon. Just this is really important, that and I don't know the message, the extent to which this has got out, and we talked about it a little bit, but in the UK, the MHRA, who decide what drugs we do and don't get access to, are going to make their own decision about obeticholic acid. Okay.
Yeah.
And there is going to be, we don't know the details of it, but the UK has much more of a commitment to the patient voice being heard. I mean, it's frankly difficult to have less than the European Medicines Agency. And so there will be a consultation, okay? We don't know what it will look like. I won't be involved in it. There's no point asking me what I think because they know what I think. but clinicians will be asked, but patient groups will be asked, and patients. And that is your time to be heard, okay? And it's important to make that as evidenced as possible based on experience rather than emotive. Okay, so you will have seen, many campaigns about drugs, which is, it's my right to have a drug, whatever it is. Well, try and make it as fact-based as possible. And there is so much experience of people out there. I mean, it is the one thing I do, think is fortunate is that amongst our patients on treatment, we have been reassuring them, you have been reassuring them, the foundation, and there is not a lot of anxiety. And absolutely clearly, those people on OCA will still be able to take it if they want to in the future, and potentially new patients can be started on it, and that will all happen if it has to. So it's not a safety thing. There will be continued availability. It will be all pain for everybody to have to do that. But get across to people that this is a standard normal therapy that large numbers of people take and are benefiting from. And the idea that you suddenly stop it because you can't believe the evidence of your own eyes about what it does is absurd. And, people accept the need for regulators to, the MHRA came about because of thalidomide, right? I'll be honest about it. So we do need to ensure the safety of treatments and that they work, because any treatment that doesn't work is inherently going to not benefit you. And of course you need to do all of that, but it's got to be in proportion, and it's got to have its feet grounded and have some common sense. And I think the message here is that this is not a brand new drug we'd like to play around with in a few people. This has been a standard part of our treatment for the last 8 years. And to suddenly have to unwind all of that, I mean, is unthinkable. Actually, it's never happened before. The other example is I don't know if I mentioned this last week. I don't think I did. Is that you will have? Did we mention about the dementia drug last week? Yeah,
we touched on it. Yeah, we touched on it a little bit last week. Yeah, was turned down by the European Medicines Agency, was approved by MHRA. And that's the first time they've taken their own decision. And so that should roll on. Ignore the fact that NICE turned it down, okay? Ignore that. That was because the evidence wasn't presented correctly, and that will get sorted out. And PBC drugs have never had any problem with NICE, and they aren't going to have a problem with the new ones. And so don't worry about that aspect. It's the regulatory approval. And we'll continue to update as well on our website about all the news about OCA as well. There's starting to put some information about the FDA, and we'll continue to do that as it progresses through as well. So if there's anything, just let us know.
Yeah.
Okay, thank you so much for your time.
A pleasure as always. And
I look forward to seeing you soon.
Mo, do you ever regret saying something as much as you regret saying that to me last time?
Yeah.
Because it's just encouraged me. It's just encouraged me, isn't it?
And every week we're just going to make it worse as well, which isn't going to help.
Last comment from me is that this is not being frivolous, okay? Anybody who knows me, I'm the most serious person you will ever come across. But we can sometimes be serious with a smile on our face. Absolutely. And it's called being human. And it's about, serious times need serious approach. These are relaxed sessions. And actually part of the being vaguely humorous about it is actually these things people remember, but in the consulting room, we're deadly serious. So please don't mistake this. This is relaxed me enjoying these sessions, which I find incredibly rewarding, and I'm very grateful that you also find them very good. I love doing them, as you all well know, but we are serious, but we're serious with a human face.
Absolutely.
George is very
highlights Mavic as well. Yeah.
George is very serious, full stop.
Yeah. Okay. Have a good day.
All right. See you later.
Bye, everyone. See you later.